great to be able to join you here at the Smyrna Rotary Club. I decided after serving in government for 9 years to leave Washington and come back to Atlanta to the Morehouse School of Medicine, and it's been probably one of the best decisions I've made, because it's great watching the Atlanta community as we come together around issues. And I'm especially grateful for the Rotary Club, Rotary International, for your work in polio. When I was director of the CDC in 1996, I believe, we spent a week in India and actually immunized 100 million children in that week against polio. And when I was trying to figure out how we did it and talking with our staff, it turned out that there were 57,000 Rotarians on the streets throughout India helping to get children immunized. So in addition to the contributions that you make financially, all over the world, Rotarians have really played a major role in seeing that children become immunized. And so it's great news that India did not have a case of polio last year. We're not quite finished with the job. I think you probably know there were more than 600 cases of polio in the world last year, and they were primarily, as you've heard, in Nigeria, Pakistan, Afghanistan, and the big challenge is primarily political now. It's there's nothing wrong with the vaccine if we can just get it to children. But for various reasons, in Afghanistan, I'm sure I don't have to explain, it's very difficult getting to children in certain parts of the world. Sometimes religion is a major barrier, such as in Nigeria. But I think we're going to get there. As we did with smallpox disease, I think we're going to eradicate this disease. And smallpox is the only disease in history that we have successfully eradicated. Because, as you know, when you say you've eradicated a disease, especially if it's contagious, it means that there are no cases in the world, so nobody's at risk for getting that disease. I remember when I was director of the CDC, we had, of course, made a lot of progress in polio in this country a long time ago, and we were giving the oral polio vaccine. And the only cases of polio that we had were people who got polio from the vaccine, because it was a live vaccine. So we made the very difficult decision in '96 to go to the injectable vaccine, which obviously you prefer not to have to use a needle. But the oral polio vaccine was the cause of the polio that we were seeing, 8 to 9 cases a year. But the bottom line is that we've made tremendous progress in medicine and public health over the years, and certainly in infectious diseases. I want to acknowledge that, but I don't want to stop there. I do want to talk about what I consider to be some of the major challenges that we're facing in medicine and public health, and my hope that Rotary will take up some of these challenges, one in particular. But let me say a word about the Satcher Health Leadership Institute, and there are a few copies of our last newsletter if somebody would like to pick up one. As you've heard, the Satcher Health Leadership Institute was established at the Morehouse School of Medicine in 2006. The story is, of course, when I came back to Morehouse in 2002, I came back to develop the National Center for Primary Care, the only national center for primary care in the country, and really had a great time those 2 years between 2002 and 2004. And then we had a leadership glitch at the Morehouse School of Medicine, and in a way it was somewhat threatening to accreditation. So I was asked by the board and the faculty to, if I would take over as interim president. And even though I had said that that was not something I was going to do when I left government, as many of you know, I served as president of Meharry Medical College for almost 12 years before I became director of the CDC. So one thing I knew I didn't want to do when I left government was to go back and become a president of an institution. But I did agree to serve, and I served for 2 years. But my concern was that if this were to happen again, that everybody wouldn't be pointing fingers at me to take over as interim president. So what I decided was that once a month, we would have a leadership retreat. And so during the 2 years that I was president, every month we had all of the top leaders, 35 of them, together for 4 hours to talk about leadership. You know, we just take leadership for granted often. And it's only in situations like that where you really stop and say, now, what do we really need from leadership? Well, what are the characteristics of leaders that are most important? So we looked at all of those things over that 2-year period. So when we were able to bring on a new president, I think many of you know our president, John Maupin, the board voted to establish the Satcher Health Leadership Institute so that this dialogue and this work on leadership would continue. And that's the origin of the Satcher Health Leadership Institute. And the chair, the Poussant Satcher Cosby Chair in Mental Health, was the result of a gift from Bill and Camille Cosby, recognizing the work that I did in government and mental health. So in 2006, Bill and Camille Cosby committed $3 million to establish this chair in mental health. So that's how we started, and our mission is really centered around the whole issue of disparities in health. Our goal is to help develop leaders who are and who will be committed to working toward eliminating disparities in health. But in addition to developing leaders, we consider ourselves to be an institute that's working ourselves to eliminate disparities in health. So we have some very innovative programs in the community with parents, for example, trying to really work to improve quality parenting. And we have programs dealing with HIV and AIDS and several other, obesity, which I'll talk a little bit about later. So we're an institute that not only is working to develop leaders, but also providing hopefully exemplary leadership in dealing with these problems. Today we have 3 leadership programs at the Morehouse School of Medicine. One is a fellowship program, and every year we take 4 or 5 people in that program. It's a 1-year program, and the people who come into it are mostly physicians or doctors of public health or clinical psychology. And they spend that year with us, concentrating a lot on health policy and how do we actually work to get the right policies in place in medicine and public health. We've attracted some very interesting young people to that program, and many of them are out doing some very interesting things. There's only one school-based health clinic in Georgia, the Whitefoot Health Clinic, and that clinic is headed by one of our graduates, Jada Moore Ruffin, and she, along with others, are now working to develop other school-based health clinics throughout the state of Georgia. So that's the kind of leadership that we're very pleased that some of our graduates are providing from the fellowship program. We have a very interesting community health leadership program, and something that's completely sort of innovative and new. And in that program, we actually invite community organizations like churches or Rotary clubs to identify people whom they think have leadership potential and could make a difference in the community in terms of health promotion and disease prevention. And so we take 12 people into that program for 12 weeks. They have to spend 1 full day with us a week for 12 weeks. And then the goal there is they would actually leave with an understanding of the things that we can do at the community level to improve health and to prevent disease. And so it's been really interesting. We have, we wrote churches asking them to recommend people. In the first group of 12, 4 of the people were pastors of churches who came and said, I want to come myself. And it turned out that that was great. One of the pastors was actually a Liberian, most of whose congregation was Liberian. And he had suffered from hypertension and diabetes, and he was really concerned that many people in his congregation were really headed for the same kind of problems. They were overweight or obese, they were not eating properly, whenever they had dinners at church, of course, they had fried chicken, not knocking your fried chicken, but they didn't have healthy foods or healthful foods. So as a result of coming to our program, he actually worked with us to develop a resource book to really help educate his congregation and to make change in terms of healthy lifestyles. And I had a chance to visit his church recently, and it's really amazing to see what he's doing. Churches are some very important institutions, especially in some of our communities. Some of our communities, churches are the most viable institutions left, and the people who come there contribute to the churches. And what we're trying to do is to work with churches to really educate, motivate, and mobilize people toward healthy lifestyles. Another one of our graduates from that program was a young lady who moved into a new community, and she enjoyed getting up in the morning and going walking or jogging. But she was told by the people in that community that it's really not safe here to do that, and so we don't advise you to do that. She didn't listen to them, but one day she came home and somebody had broken into her apartment and some other things happened. So what she decided as a result of being in our program was to start a very innovative neighborhood watch where, you not only put up the signs and people in the community agree to call if they see anything, but she actually got people out of their homes into the street occasionally to have events. People started walking together in the community. And so those are the kinds of things that are happening because not only are we hopefully teaching the community health leaders some things, but they're teaching us a lot about how to bridge this gap between academia and community. We do a lot of great research. We've made tremendous progress in treating cardiovascular disease, for example, and in treating cancer. Mortality rates have declined dramatically. Where we're having trouble is in health promotion and disease prevention, getting people to really modify their lifestyles in a way that's consistent with good health. The cost of our healthcare system, of course, is, as you know, going through the roof. When I left government in 2002, we've talked about the fact that we were spending $1.3 trillion a year on healthcare in this country, more than any other country in the world. Well, today, you probably know, we're spending over $2.5 trillion a year, and we're spending over $8,000 per capita on health and healthcare in this country. And we've tried a lot of innovative things, and there's some other things we can do. I'm sure we can improve the incentives in the health system, part of which the healthcare reform legislation is attempting to do. But ultimately, I think until we can get the American people to take more seriously health promotion and disease prevention, the cost of healthcare is going to continue to go up. As you probably know, Medicare is our most expensive healthcare program. And 80% of the cost of Medicare is related to preventable diseases. 80% of what we spend to treat people in Medicare are for diseases that could have been prevented in the first place. So you see why we need to get out of the hospitals and the clinics and really figure out how to work with people in the community to begin to change lifestyle. And that's more difficult in some communities than others. So we're very pleased with that program. And our last program that I'll mention is a parenting program. Now, in the communities around us, and that's the Atlanta University Center, there are a lot of single parent households. In fact, 80% of them are single parents. In those communities, in many cases, they're not grocery stores where people can buy fresh fruits and vegetables, and in many cases, not safe to get up and walk out in the street. So a lot of challenges. What we decided a couple of years ago was that while some of those challenges were going to be there for a long period of time, we could at least work with parents to see if we can help them to improve the quality of parenting. Now, it's not that we thought we had the answers. because, we don't necessarily appreciate what those parents go through, what it's like to live in their situations. But our theory was that the answer to the issue of quality parenting was in fact in that community. And so our role was to work with them to help find those answers, listening to them a lot, but also when we had something to contribute it. And just a great young lady working with me, Dr. Martha Okafor, who is an anthropologist and who worked in public health in Georgia for 9 years and before she joined me. But she's done a great job with that parenting program, and together they are coming up with strategies to improve parenting. We believe that there are two things, for example, that we can do. We believe that we can promote mental health or behavioral health in children, because that starts, in utero while the baby is developing in the womb. The impact that nutrition has on mental health is amazing in utero. The impact that stress has, a mother living in stress or suffering from violence, the impact that it has on that developing baby or the developing fetus is tremendous. So we talk about those kinds of things, but we also talk about, the importance of the mother's diet, during pregnancy and what they can contribute to that developing baby, but also when the baby is born, how critical communication is. The earlier the better. In fact, we encourage some mothers to start talking to their babies before they're born, and some mothers do. It's an amazing thing what can be accomplished in those early years of life in terms of mental health and behavioral health. And in time, of course, we hope to see an impact of that on readiness for school and meeting developmental guidelines that we can measure and things like that. We're also interested in the impact that could have on childhood obesity, because we know several things. We know that the diet of the mother influences the risk that the child will be obese. And if you don't know it, Georgia has a major problem of childhood obesity. One of the leaders in childhood obesity in the country is the state of Georgia. And we believe that combating that problem must start, as early as possible. Whether or not a baby is breastfed determines the risk of childhood obesity. You may not can figure that one out, but believe me, babies who are breastfed are less likely to be obese than babies who are not. So this whole nutrition thing and patterns of nutrition start early. But so we have that parenting program, which I'm very excited about, and it's gathering a lot of excitement. One of the things that's developed, of course, is we've identified a group of what we call parent leaders. Some people who are, who are grandparents now, but who are very interested in working with younger parents in the community, and some of them are able to provide a lot of advice to young people. You remember when that used to happen a lot before families were sort of separated. But so what we're doing is trying to bring together people in the community who have experience and wisdom, but who also care a lot about what's happening to these families. And that program is working out quite well. It's, I just had lunch with a group of these parent leaders 2 weeks ago, and I was very, very impressed. Well, what I want to talk about for these last 5 to 10 minutes is the Surgeon General's prescription. Now, I didn't pass these out before. If you want, someone that wants to pass them out, I can pick them up at the end of the program. But I was out in Palm Springs, California last week with President Clinton and his daughter Chelsea. And as many of you know, the Clinton Foundation has adopted this issue of childhood obesity as a major project. So has the Robert Johnson Foundation. So you may say, well, why is everybody getting involved in the childhood obesity? Well, you may have asked that question about polio several years ago. And when I tell you today that last year we had over 600 cases of polio, I can tell you that there were millions of cases of childhood obesity last year. I can tell you that when I was director of the CDC, for example, in 1990, we were concerned because 15% of the people in most states were obese, according to body mass index. So By the time that I released the Surgeon General's report on overweight and obesity in 2001, December 2001, 33% of the American people were obese. And 65% of the American people were either overweight or obese. That's how rapidly it had changed. And the thing that really concerned us was that among children, between 1980 and 2000, overweight and obesity tripled among children. And you will never hear us talk about obesity in children without saying overweight and obesity. And the reason for that is children develop at different rates. So it's not as easy to know whether you're dealing with a child who's obese or whether that child's pattern of growth is different. So we use overweight and obesity, and we use percentiles. If a child is above the 85 percentile, then we said that child is overweight or at risk. Or if they're above the 95 percentile, we say that they're overweight or obese and really obese. So that's the way we do it in children. Now, in adults, we say, I don't know how many of you have dealt with body mass index, but it's a way of relating height and weight. And in adults, we say if the body mass index is over 30, then you're obese. If it's over 25, you're overweight. And obviously, there are guidelines that are not perfect because people who have a lot of muscles, people who work out a lot, athletes, will have a higher body mass index.